Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the 5th episode of our ongoing series, a program on JAK inhibitors for atopic dermatitis, hosted by expert dermatologist Dr. Christopher Bunick, Associate Professor of Dermatology at Yale University in New Haven, Connecticut. Our 5th episode, Choosing the Right Path, JAK Inhibitors or Biologics for Atopic Dermatitis, features Dr. Naiem Issa, Medical Director of Research and Academics at Forefront Dermatology in Vienna, Virginia, and Professor of Dermatology at George Washington University and the University of Miami.
Welcome to today's podcast. It is our 5th episode in the LiveDerm series program on JAK inhibitors for atopic dermatitis. And this 5th episode is titled Choosing the Right Path, JAK Inhibitors or Biologics for Atopic Dermatitis. I'm Dr. Christopher Bunick, and I'm really thrilled to have you here today to listen to a good friend and colleague of mine, Dr. Naiem Issa. We're going to be diving into a very important discussion on systemic treatments for atopic dermatitis, and Dr. Naiem Issa is a leading expert in dermatology, and I'm going to ask Dr. Issa, could you please introduce yourself to our audience today?
Well, wonderful. Thank you, Dr. Bunick. It is a great pleasure to share this day with you and this podcast and with all of you who are listening. So my name is Naiem Issa. I'm a board-certified dermatologist. For those who don't know, I work with Forefront Dermatology based out of Vienna, Virginia, which is right in DC, and serve as the medical director of research and academics for Forefront at large. And I'm also a professor of dermatology at George Washington University in DC, as well as the University of Miami. And I love treating, all inflammatory skin diseases and looking at innovative therapies, and especially atopic dermatitis. So thanks so much.
Yeah, and one of the reasons Naiem and I are such good friends is we both like to think at a molecular level.
Absolutely.
All right. So setting that stage with that, atopic dermatitis has seen a huge expansion of systemic treatment options over recent years, and it's ever expanding. And in particular, this expansion has included the introduction of JAK inhibitors and biologic therapies. And today, we're really going to explore why JAK inhibitors might be the right choice for many dermatology patients suffering from moderate to severe atopic dermatitis. I really want to emphasize that it's important to individualize atopic treatment approaches, and there's really a need for effective patient-centered therapies for those really suffering from moderate to severe atopic dermatitis. So with that background, let's get started. Dr. Issa, can you explain for our audience the mechanisms of action for both JAK inhibitors and biologics?
Absolutely. So I think it's important to set the stage in two different viewpoints, if you will. One is for the dermatology colleagues who are listening to this podcast, and also the way that I like to explain it to my patients in the room and patient parents. I'll start with the patient perspective first for a mechanism of action. The way I like to explain this is that atopic dermatitis is a very complex and immune system related kind of condition that goes haywire, right? So you have a lot of these cytokines, which are these immune players that are outside of the cell, and they have to relay signals into the cell, right? And nature is smart and has developed a mechanism by which they can take all these various signals and put a bottleneck on it. And when you have this bottleneck, right, they can only signal through, a set number of ways. And this set number of ways is through the Janus kinases or the JAKs. So they're kind of tuned the system for you. And so I tell them when you hit the bottleneck, you could have a broad ranging of effects, that could be quite effective, and quite rapid. So that's what I tell, the patients. And then when I talk to my colleagues, either in a venue like this or, in conferences, is that we get a little bit more granular. You have all your interleukins, you have 4, 13, 31. You have any number you can pick any number, put interleukin in front of it. You probably find it involved in atopic dermatitis, right? And all of these chemokines, and all the receptors, right? So all these interleukins, they have to signal through their cognate receptors, right? Which are on various immune cells as well as keratinocytes, among other cellular players, even fibroblasts, in some cases, right? And so the main players, as you know, is interleukin 4, 13, and 31. And what they do is they signal through different dimer receptors, like your type 1 receptor, your type 2 receptors, so on and so forth. And these interleukin signal, again, through the JAKs, you have 1, 2, 3, as well as a TYK2 that fall into that class. And then they relay the signal through recruiting STAT scaffolding proteins. So STAT come in, they get phosphorylized by the cognate JAKs, and then the STATs dimerize, they go to the nucleus, and then they cause transcription, where you have more genes being transcribed for further cytokines, and that gets produced into proteins and then causes the whole thing to go more haywire and has a positive feedback loop.
No, excellent. Thank you. Absolutely, you hit on a point about the molecular heterogeneity of atopic dermatitis. And this is something that we're really learning a lot about over the last couple of years. And it's sort of driving the need for this personalized medicine approach towards treating atopic dermatitis, because under that molecular endotype, or that molecular heterogeneity, actually drives the fact that we have this clinical heterogeneity in the morphology of what we see in our patients for atopic dermatitis. Not every atopic dermatitis moderate to severe patient is the same. They can present very differently. And I think what you're describing really explains why we see such variability across our patients. Is there anything that makes JAK inhibitors stand out in terms of their approach to managing atopic dermatitis for you?
Yeah, so again, it goes back to the basics, right? So if you understand the basics, you understand the science, and you understand what efficacy you're going to get. It's as simple as that, right? So the signal has to come from the outside in, right? And again, to reiterate, I like this idea of nature is smart, right? And has come up with this mechanism of transducing the signal. And you're cutting off the signal at these focal points, right? These, I would say 4 major focal points, but they combine with each other, right? But nonetheless, they're the JAKs. So look, I like to be simple-minded, because simplicity is key. So if you have whatever signal at the top, right, they have to all be relayed through these focal points. And so if you're cutting off at the focal point, more often than not, you are going to get an effect. And you see that across all the JAK clinical trials, right? They're pretty efficacious. But furthermore, right, you see that the onset of the efficacy is very rapid. And for that, and that makes a lot of sense given that MOA, right? So small molecules, right? These JAK inhibitors are small molecules. They diffuse into the cell fairly rapidly, and they rapidly bind, to their target, right? Whatever JAK that's implicated at the time, right? And because of this rapid pharmacokinetics, you will anticipate a rapid effect, especially with the itch. And that really stands out to me, because you find that these JAKs are found also in the nerves. And as we all know, the nerves is the gateway to the brain and transducing itch, right? So again, the MOA makes complete sense, right, with how you see the efficacy of these primary and secondary endpoints that you see in the trials and their speed up on.
No, thank you, Naiem. I really like how you're connecting here the mechanism of action with clinical response or clinical efficacy. So touching on that clinical efficacy a little bit more, we've actually seen a few studies comparing the efficacy of JAK inhibitors and biologics head to head. Can you share some insights on these findings, particularly regarding how not only the patients can see very quick improvements with the JAK inhibitors, but also obtaining these optimal treatment targets?
Absolutely. And I think this kind of discussion is also helpful at the patient level too. So you may call me crazy, Chris, because you know that I'm a crazy, dermatologist, but sometimes I actually bring these graphs into the room, right? And I actually show the patients these 2 splitting graphs. So what are we talking about first? Let me take a step back. So number one, you have these head-to-head studies that are comparing dupilumab with either of the 2 major JAK inhibitors, upadacitinib in one set of trials and abrocitinib in another set of trials, right? Essentially, they were looking at the itch response, right, which is a secondary endpoint, an itch response within the first 14 days in either one of these trials, right? And they wanted to see day-to-day what that itch response looked like. And so by day 2, they found that there was a statistically significantly greater response in itch reduction in the JAK inhibitor group, either or, right, in either one of those studies, compared to dupilumab, the biologic, which, by the way, which we didn't say the MOA, but it binds to the interleukin 4 receptor alpha, which is part of that heterodimer receptor complex, right, before the signal gets to the JAK. So you have evidence here that early on you have a rapid induction of itch response. All right. And then you also see similarly, you see that trend with the clearance of the skin as well, rapid clearance of skin. All right. And furthermore, you see that once it hits that maximal response, it maintains that with very minimal variations. So you have durability over time. So we have evidence now showing that JAK inhibitors are getting those endpoints faster and superior to a biologic in this case.
Yeah, absolutely. And just to clarify for our audience, the upadacitinib versus dupilumab was the Heads Up trial, and that was a 24-week trial of upadacitinib 30 milligrams daily versus dupilumab by label in adults. And then the abrocitinib versus dupilumab trial was the JDARE trial, 26-week trial of abrocitinib 200 milligrams daily versus the dupilumab on label. And Naiem, so beyond those trials, we actually have new data, the Level Up study that just came out. Do you have any thoughts about Level Up?
Yes, and I hope I hope they have heard of it at least, but if not, this is a great venue to hear about that. This is another head-to-head study, but with a different kind of flavor of upadacitinib compared to dupilumab, right? So why on earth would another one be done, right? If we just talked about that, the Heads Up trials, right? The idea here is that we collectively as a community, dermatologists, industry stakeholders, as well as patients and patient families, we want to strive for the next milestone, right? And this next milestone is having a comprehensive and holistic response. And how do we define this? We do this with a composite endpoint. And so here it's taking the skin clearance as well as the itch reduction, and we're putting them together. So we're not looking at each one by itself, but here the primary endpoint has become 90% skin clearance or EASI 90, as well as attaining minimal to no itch or an itch score of 0 to 1 from their baseline. So you have to hit both endpoints in order to be considered a responder in the Level Up trial. And indeed, what was found is that those that were on upadacitinib had superiority compared to dupilumab on this new composite endpoint.
Absolutely. And just to provide some exact numbers to our audience, it was at week 16 primary endpoint, the most stringent endpoint ever in an atopic dermatitis clinical trial, EASI 90, and as you said, itch NRS is 0 or 1. 19.9% for upadacitinib and patients hitting that endpoint, and 8.9% for dupilumab. So that is, almost double the response rate for patients receiving the upadacitinib in the Level Up trial. Now, one of the things that's really amazing about all these head-to-head trials is, we crave head-to-head trials in dermatology because it helps answer questions theoretically in an unbiased way. But when we don't have these head-to-head trials, we use network meta-analyses, right? Indirect measures or comparisons to be able to figure out what might be better than the other medication at achieving certain endpoints. And the network meta-analyses in atopic dermatitis, I always kind of joke, we just had the Paris Olympics. I joke the gold, the silver, and the bronze in the network meta-analyses are all JAK inhibitors, right? You have the upadacitinib 30 milligram dose of abrocitinib 200 milligram dose, UPA 15 milligram dose. With the caveat, the weeks for the abrocitinib, I think, was week 12, not week 16 data. But the point being, it's gold, silver, bronze, JAK inhibitor. And what's interesting is these clinical trial head-to-head trials that we were just talking about, particularly Level Up, they actually mirror what's happening in the network meta-analyses, meaning that it's not like we're getting a completely different result in the head-to-head clinical trial. It's mirroring what's the right word? It's compatible with what we're seeing in the network meta-analyses. And I think that's very reassuring for both providers and patients.
And also for statisticians too, because we always have this argument, right, with these network meta-analyses. Well, are the methods sound, right? How applicable are these methods? So before we'd always have that stigmata saying, well, you have this network meta-analysis, it's not the real deal, et cetera. Well, this is now more proof in the pudding, right, that there's an alignment. So I really like that perspective as well.
Yeah. So, Naiem, let's keep talking about some of these advantages of JAK inhibitors. One of the appeals of JAK inhibitors is their oral administration, and this contrasts with the injectable nature of biologics. How do you see this benefiting patients, especially in terms of convenience and adherence?
It's huge, and there's a lot of data actually on this that folks can read in the literature. But even in anecdotal experience, is that you have patients who have different preferences here. So when you provide them a platter, right, of these innovative treatments and a way for them to have to not deal with needles, especially for those who are needle phobic or tend to have pain with injections even, this is a great option for them. This gives them a choice. They feel empowered to make the choice. And when they start feeling better, right, and that usually happens, within just the first few days as you look at the data, the compliance and adherence is much higher. And these patients will tell it to you themselves. They feel better, they feel motivated, they don't have to deal with a needle, they like all of that. So all of the adherence and compliance goes through the roof.
Do you have any particular tricks in order to help your patients stay compliant with their medication?
So I love to tell them this quote. Imagine that you could live itch-free. And I put this in quotes because I also got this from my colleagues at Dermaleave, right, where they have their topical products. And I just love that statement, and I had to adopt it myself. So I tell folks, imagine that you could live itch-free. And they said, is that possible? Because I've been living like this for years, right? And so you give these folks hope, and when they start to feel it, they believe it, and then they become adherent.
Very good. I take a page from my acne patients, where I usually tell them to rubber band their medicine around their toothbrush and toothpaste so that they never forget. So you just sort of rubber band your medicine around the toothbrush and toothpaste. Never forget if you take it at that time. All right. So, obviously we know that atopic dermatitis affects more than just skin, because we were just talking about the rapid itch reduction from taking these JAK inhibitors, which are functioning right inside the cell at the signaling that's driving that transcriptional program in the cell. So can you discuss a little bit more about how JAK inhibitors might provide broader benefits, particularly in addressing psychological impacts of the disease, like itch, not only itch, but itch-related sleep issues, quality of life? You're sort of just touching on that. Can you expand on that into how JAK inhibitors are really transforming this patient experience?
Yeah, absolutely. So what's often not talked about, prior to the development, of JAKs and now these new efficacy endpoints, is truly the patient experience and these, patient-reported outcomes, or PROs. Particularly, they have these sleep scores, right? That they have the scale out of 10. They have their daily life quality index, or DLQIs. You can put whatever PRO that you want, but essentially you start seeing a similar trend. As their itch and their skin gets better, and particularly when both of them get better at the same time, you see that rapid velocity of the reduction in those PROs, right? And you like to see that happen early. And guess what? Our colleagues, they've done these studies for us, and we can even present them to patients, right? They've done these associations and said, okay, if your itch gets down to 0 in the first 16 weeks or the first 12 weeks, yeah, you're going to sleep better. They showed those metrics too, right? As well as the quality of life. So it is there. Yes, and it makes sense, just pontificating about, if you look better and you feel better, then ultimately your quality of life is better. But it's nice to see that there are these endpoints that are validated, not just in the United States, but also abroad, right? You have these validated endpoints. And with the use of JAK inhibitors, you see a rapid reduction in those metrics correlating to increased quality of life.
Yeah, and I think the JAK inhibitors, a undervalued benefit of the JAK inhibitors is their potent anti-inflammatory nature. What do you think about their impact on systemic inflammation, lowering systemic inflammation, and potentially improving comorbid inflammatory conditions? Well, what do you think about that?
I think that is a key point in our discussions amongst ourselves and the patients. So, atopic dermatitis, let alone, cutaneous inflammatory conditions with a, greater surface area of involvement, right? We have figured out that there is this, internal inflammatory component that leads to various comorbidities, right? And they may be similar in some parts different, like atopic dermatitis and psoriasis are different conditions, but they share some pathways, but their comorbidities are largely the same if you leave them unchecked. right? And sometimes, especially with the itch component in atopic dermatitis, they can lead to mental changes as well, in psychiatric comorbidities. So all this involved with the systemic inflammation. I like to discuss with my patients and say, look, atopic dermatitis is more than just skin deep. If you have inflammation that's unchecked, right, then you could lead to comorbidities down the road. And there's various studies, and you can look at all of these to see, like, is there, what's the risk of having strokes, cardiovascular comorbidities, so on and so forth. So I think it's quite important, to have medications like JAKs that have, remember, they block that funnel, right, those focal points of inflammation, because we have, it's heterogeneous disease. Atopic dermatitis is heterogeneous, multiple components leading to heterogeneous inflammation. So by blocking that focal point, you will see benefits down the road, right, for those comorbidities. So that's why I'm a big fan of that.
We live in a time when the buzzword is real world efficacy, or real world effectiveness of therapeutics. And we know that is crucial. Are you able to share any cases or examples where patients had better outcomes with JAK inhibitors compared to biologics in your practice?
So yeah, actually one particular case comes to mind, and I had an elderly person actually with severe atopic dermatitis and a distant history of a myocardial infarction about over 10 years prior. And so he had actually tried both biologics that were available, right, as well as prednisone and phototherapy, tried all these creams, but he just had raging atopic dermatitis. And he was a military man. This is a guy who nothing phases him, but to the point now he said, well, you know what, this actually affects my life and I need something. So this is where I put him on a JAK inhibitor, right? After discussing the risks and benefits, we'll talk about safety in a little later on in this segment. But after we dotted all our I's and crossed all our T's, we put him on, and it was unbelievable to get a phone call about 48 hours later to say, I can sleep again, right? Elderly gentleman, 75 years old, right? And long-term history, over 30 years of atopic dermatitis, which is almost about a time that we see in the studies, right? This median time of disease, right? And tried the biologics as well as oral corticosteroids. Nothing touched him until a JAK inhibitor came to play.
Yeah, just a few thoughts. I think that's amazing that you did that treatment, because it was the right choice, in my opinion. First of all, the corticosteroids that he tried were probably more risky for his heart history than the JAK inhibitors. And in fact, we know that from the long-term safety data, which, as you said, we're going to talk about more, but the safety, even in the patients that have had prior MI, stroke, and other cardiovascular or risk or events, I mean, these JAK inhibitors are proving to be way safer than we could have ever hoped for. And in addition to those factors, you mentioned sleep. Well, we know that patients that don't sleep very well or don't get enough sleep, that alone can increase inflammation and heart attack risk or cardiovascular risk. So just getting good night's sleep, you're probably having a greater impact on your patient's cardiovascular health by getting them to sleep than anything you could consider as a risk factor with JAK inhibitors, because as we're talking about, the JAK inhibitors in a safety, long-term safety, are proving to be incredibly safe with very minimal cardiovascular risks.
You hit the nail on the head. Exactly.
Since we've been talking about safety here a little bit, and ways in which the JAK inhibitors are proving to be so safe that you can use them in your patient with history of MI, over 70 years old, doing incredibly well. Safety, to all of our colleagues and our listeners, is a concern with any systemic treatment, let alone JAK inhibitors. What are the common safety issues associated with JAK inhibitors, and how are you managing these risks in your practice?
It's a great question, and it's like the ultimate question, right? That comes down, because I think most folks are convinced of efficacy. They can see those graphs all day, but safety becomes a nuanced conversation, right? And we're here to talk about this good safety profiles. So first, I'm actually going to bring it to the basics real quick, because I think a lot of people may just gloss over the fact that you have typically 16 or 12-week safety data, and then you have the long-term extension, and they're presented a little bit differently, right? In your pivotal trials, which is either 12 or 16 week, depending on the program that was involved, right? They have the placebo-controlled parts, right? And that's so you have a comparison, the two charts where you have a placebo and then you have your active groups, usually the two doses. If it's, upadacitinib 1530 milligrams compared to placebo, and then you have abrocitinib 100 and 200 milligrams compared to placebo, right? So here you have that comparative portion of it, and is usually written as an absolute number / a percentage of the total there. Not usually that patient year stuff. Now, when you get to the long-term extension, you've lost the placebo part, so you only have active arms. And so because you have different dropout rates at different times, right? Again, these are long-term studies, right? And it keeps getting longer as we're talking, right? So with the single arm, right? There's a single active arm, as we say. You cannot compare to placebo anymore, right? So it's a different conversation to be had, all right? And then furthermore, to be able to try to standardize the exposure of these patients, we use this concept of 100 patient years, right? Event rate per 100 patient years. So what does that even mean, right? Because this is kind of where people kind of get bored, at part of the conversation, right? But it's actually a pretty fun statistical thing. So to make it really easy, if you have 100 patient on a drug for a year, that's 100 patient years. Makes sense, right? However, what if you had 50 patients on drug for 2 years? That's also 100 patient years. What if you had 200 patients on drug for 6 months? That's also 100 patient years. So essentially, you can get this standard ratio of 100 patient years in many different ways. Hence the reason why we use the standardization. Then you look at the event rates, per 100 patient years. So now that we've set the stage, right, you have your patient year part, and then you have your pivotal part, right, 12 or 16 weeks. You have two different conversations. So number one, when we talk about safety in the pivotal part, that's to get the patients through that primary endpoint that the FDA deemed was appropriate in order to get the label and to get approved to be put in the market, right? So looking at the 16-week data, you see that in general, the boxed warning, events that we typically think about, the infection risk, right? The major adverse cardiovascular events, the cutaneous non-melanoma skin cancers, as well as other malignancies that's coupled into one umbrella, and lastly the thromboembolic events. You see that truly there is almost no difference between placebo group and either one of the JAK inhibitors that we have talked about in those pivotal phases, and that's a critical thing to discuss because the way I personally look at it is, first, let me get you better in the immediate period. What does that safety signal look like in that immediate period, meaning 12 or 16 weeks, given the pivotal trials? I tell them this, tell my patients this safety data, and then they feel comfortable because then we can broach the conversation again in 12 or 16 weeks of whether or not they want to continue. And then I bring in the long-term safety data at that point. And, spoiler alert, that data seems pretty similar in the long-term safety as well, just written as per 100 patient years. So all of this, and then you asked me the question of what is the main signals that we tend to look for. So I mentioned the boxed warning, the big four, right? But in particularly with the infection, one of those that always gets highlighted is herpes zoster. So I just wanted to make a note about zoster, right? And you probably may agree with me on this, is that always we try to get the vaccination, as early as possible before starting the treatment course. And always we like to do live vaccinations prior to initiating, or we will hold the medications prior to a live vaccination. But to my knowledge, there's no contraindication for non-live, vaccinations as well.
Yeah, it's a really important point about the herpes zoster because in these long-term trials, or the trial that's being evaluated long-term for safety, these patients, only about 5% or less of the patients actually were vaccinated. So the data set where we're getting 3 to 5 events per 100 patient years of herpes zoster is biased towards herpes zoster because most of them were not vaccinated. So if you're vaccinating your patients properly before JAK inhibitor use for patients that are either immunosuppressed or more elderly or more at high risk, certainly you're going to probably see lower event rates than what is seen in these trials. At least that would be the hypothesis. So Go ahead.
Actually, Chris, I don't mean to cut you off, but it's very interesting. So you brought up this demographic profile, and I think a lot of folks tend to also gloss over who was included in trials, and that dictates, your efficacy and safety signals. Particular, and I think this is an interesting fact. So in that Level Up study, did you know that people, if there were females who were on oral contraceptives, during the trial, as well as folks who actually were smokers as well, they didn't screen those patients out. They were actually included in the trials. And nonetheless, the safety signals, to placebo were comparable. That's very important to note, because some folks would think that it's a true contraindication, but it's not. It's relative, and that's a discussion to be had. But now that we have more data, it's a more sprightly conversation, if you will.
Yeah, so that's a very good point. So the upadacitinib clinical trials that led to the 5-year long-term safety data that's been presented at several conferences now actually enrolled patients with comorbidities that mirrored real-world patients. And for example, 50% or so had at least one cardiovascular risk factor, 30% were smokers, and 20% were females that were on OCPs, as you just mentioned, but not one developed any type of thromboembolic event in those trials. So that is an incredible, it's an incredible testament to the safety of these JAK inhibitors in everyday Americans and throughout the world, everyday people that are on, whether they're smoking, whether on OCPs, whether they're enjoying too much good food, like many of us do, and it's reassuring. It's a very reassuring thing,
right? And Chris, I think you had a very wonderful study that you published in the Journal of Drugs and Dermatology, looking at atopic dermatitis and a number of systemic medications, including like methotrexate and cyclosporin, as well as oral corticosteroids, you name it, in a certain cohort. And I actually would love for you to expound on that, because my takeaway from your seminal paper here was that there was such a higher risk of these boxed warning events that we put out. We found them more in the corticosteroids than any of the JAK inhibitors. I would love for you to expound on that for us.
Yeah, so my research group, the thinking was just to ask a simple question. There was such an uproar when the JAK inhibitors, particularly upadacitinib and abrocitinib, were first approved in atopic dermatitis, such an uproar about the box warning. Are they safe? Can we use them? And I remember the days pre-dupilumab where you were using methotrexate, cyclosporin, systemic steroids, and you would pat yourself on the back if you got a patient better. I'm such a good doctor. I used one of these systemic medicines. I did so good. The patient's doing well. And I just asked a simple question based on my own clinical experience was, well, what is the actual, are we able to compare the JAK inhibitor safety rates to these other traditional small molecules like I said, methotrexate, cyclosporin, as well as steroids? Because it was a very important question to really put into context the safety. And I think that's what happened, is there was a lot of uproar without proper context. And so what we showed in this paper, and now a lot of people, some people criticize the original data because it's not all atopic dermatitis patients in which we took the data. Well, the answer is the reason we did that was because it didn't exist. People hadn't gone into the databases, gotten that data. It wasn't on people's radar at the time we were working on this particular project. So we had to use the data that was available to us. And the data that was available to us, we just asked this question. We did the comparison. And what we found was, as you said, that the JAK inhibitors, abrocitinib, upadacitinib, any of the doses, were either equally or more safe than all the drugs that we looked at, with the worst being the oral corticosteroids. And it was pretty impressive how severe these steroids can cause harm to patients, at least based on the data sets that we used. And so the idea behind, or the implications of this paper, number one, are we saw in the 2024 atopic dermatitis AAD guidelines, basically a argument against the use of systemic corticosteroids for AD. So I'm 100% in agreement with that, and I know you are as well. And this is directly related, directly in agreement with what we found in this paper. And so the idea behind the JDD paper ultimately was to give reassurance to dermatologists. Wait a second, when you're thinking of a pecking order of therapies for severe, moderate, severe atopic dermatitis, the JAK inhibitors are actually positioned ahead of all the traditional immunosuppressants that you've previously considered. And now, a couple of years later from that paper, we have the long-term safety data, we have head-to-head trials like Level Up, we have network meta-analyses, and you can even go so far, Naiem, as to say, well, JAK inhibitors should be, they may not be based on FDA, but they should be first-line agents because of their efficacy and safety.
Absolutely. And what I found surprising, and I'm just trying to recall the numbers we saw in the fold difference, right, between corticosteroids and like any of the JAKs, like anywhere between tenfold difference, right, tenfold increase of the risks in these different groups, right, for the different safety signals in corticosteroids. And it's unbelievable to me. This, like, we just throw these out, to patients, and we have this evidence now in front of us. I think that's wonderful. And a second point, to your testament here is that the difference in the dosages, right? So to go to the package insert for the JAK inhibitors for both upadacitinib and abrocitinib, you will see that you have the ability, based on your discretion, to increase the dosing when you find that you're not getting a appropriate efficacious response, right? There's no timeline for which you can do that. However, it is based on your discretion as the HCP, right? So for those of you who are also a little bit concerned about upping the dose because of potential safety, well, Dr. Bunick's paper is also very helpful in showing that those, per 100 patient years, those rates are quite similar between the two groups, and also now in the long-term extension safety studies as well. So I think it's an important point for us to iterate.
Yeah, and I'll throw in the fact that, remember that the boxed warning is a class warning that was derived really from the use of tofacitinib in rheumatoid arthritis patients that were 50 years old or more with cardiovascular comorbidities, background of systemic steroids and methotrexate use. We know that topical ruxolitinib has a boxed warning, but oral ruxolitinib does not. And I've made a case both at the podium at conferences and as well as in publications that we have over, I believe, 50 medicines in dermatology with boxed warnings, and that doesn't even include the ibuprofen that we might take on a regular basis over the counter, which also has a boxed warning. And so this just, again, the reason to bring all this up is just to highlight the important long-term safety that we're getting from the JAK inhibitors in atopic dermatitis. It could not be any more stellar and exciting than we could have hoped for when they first launched. Now, I do want to touch on one issue, though, because there are safety issues arising in the biologics now, particularly surrounding dupilumab and increased risk possibly of cutaneous T-cell lymphoma. What are your thoughts there, Naiem?
It's a hot topic, right? And we still, the jury is not out yet, right? So we're finding some of these studies that are saying, okay, there is a potential link. There's some the new article in the JAD that came out a couple of months ago that suggested this, but there's also some data that says like, well, it's not a true association. We're not sure. So I'm in the camp right now where we just kind of, watch this, and we have to think about whether or not these patients, do they truly have atopic dermatitis, and should they have been biopsied in order to get to this result? So this is one of those where we still have to study. There's some evidence, but I'm still waiting for more evidence. It's a tough one to pin, and if we pin that has a lot of implications, right?
Yeah, and I'll just mention that lebrikizumab also had a couple cutaneous T-cell lymphoma cases in its clinical trial patients. And so I think that this is an area of hot investigation. And for those experts across the country in CTCL, this is good to stimulate their thinking.
Right. If there was a biomarker one of these days to be able to find that early on, I think you will have hit the nail on the head.
So you mentioned composite endpoints and how the Level Up trial is really pushing the standard of care in dermatology with how these JAK inhibitors, particularly upadacitinib in this particular trial, hit this, was superior to dupilumab in hitting this composite endpoint. So let's talk a little bit more about achieving optimal treatment targets with JAK inhibitors. So upadacitinib in particular has demonstrated this remarkable efficacy in helping patients with AD achieve these optimal treatment targets. That means like EASI-90 and itch NRS of 0 or 1. And as I said, this was clearly shown in the recent Level Up. Now, I should clarify, that's period 1 of Level Up. There's a period 2 of Level Up where patients were switching either doses or from dupilumab to upadacitinib. And so that data is not out yet, although I think it's coming hopefully by the end of the year. And that'll be very interesting as well. But biologics often have only been associated with partial improvement. How do you see JAK inhibitors like upadacitinib elevating the standard of care in atopic dermatitis?
So perfect question, right? So there are a number of patients who are lacking that endpoint that is desired, right? And that's well set in certain trials, such as the J trials and the Heads Up. And there's patients who fail to achieve the endpoint, right? Like the EASI-75, which is the primary endpoint, or IGA 0 of 1 with a 2-point drop. These patients were then put into the JAK inhibitor groups. So there are trials that have this, and they showed that they were able to actually capture an effect in those biologic failures. In particular, Dupi, there are no studies with tralokinumab at this time showing that. But there is data on this, and that actually helps guide my decision making too. Because sometimes you have patients who are already on these medications and not sure what to do next, right? So this is some good evidence.
In my particular practice, probably the data that impacted me the most in 2023 was the target derm patient-reported outcome of itch and its relationship to quality of life in atopic dermatitis patients. And what they ultimately observed in this data set was that if a patient's itch, atopic dermatitis patient's itch was scored 0 or 1 on the 10-point NRS scale, if it was 0 or 1, then they had a certain high quality of life. But if they had an itch of just 2 or 3, so if you just bumped up one little notch on that scale to an itch of 2 or 3, you had a 40% drop, 30 to 40% drop in your quality of life. And to me, that was an astounding wake-up call to me in my practice to be able to go to patients and say, wait a second, your skin may be 80, 90% clear. You may be happy from a skin standpoint, but hold on, where is your itch? Because if I had a patient who may have been 8 out of 10 and now was 4 out of 10, I was thinking I was doing a great job. But this data now says, wait a second, we need a whole new level, a whole new standard of taking care of atopic dermatitis patients. If their itch isn't 0 or 1, you're not doing well enough for the patient and their quality of life. And that is where the Level Up composite endpoint is so important. And the AHEAD recommendations now for AD treatment targets are, in fact, EASI-90 and itch NRS of 0 or 1. And so these are now being considered the optimal targets for patients with AD. And going forward, I really encourage all our listeners, make sure you're asking your AD patients not just about the skin, but the itch. And don't be afraid. I think that for me in my own practice, when you had a patient that was improved on a biologic, is sort of, you're a little bit, or I was a little bit afraid to sometimes switch to other medicines, because especially early on in the launch, because, well, the patient says they're doing better. What if they get worse? But I think that was reframing my thinking. It's not be afraid of switching and them getting worse. It's actually, wait a second, if their care is not reaching these optimal targets, then I'm not doing as good as I need to for the patients. And that has really at least helped me in my practice know when to switch and say, you know what, I'm sorry. I know you've been on this for a while. I know we've talked about you're happy maybe with the skin clearance, but you're not happy with the itch. Well, now we have data to say it is worthwhile for you to consider switching to a different medication, particularly the oral JAK inhibitors, because of their high efficacy, safety, and itch relief and quick onset of action, as you've talked about.
I just would like to mention one thing. It's 100%, the itch is such an important part of the quality of life. And we have been talking about the orals, but just for a moment, just we could educate our listeners about the topical, the one and only topical, because sometimes I think we forget actually just how powerful even a topical JAK inhibitor does. And you're familiar with this data, Chris. I think we've talked about this before, but we know we have rapidity, right, of reduction. But are you familiar with that phase 2, open label single arm trial for ruxolitinib? And you see that drastic reduction of itch that happens in 15 minutes upon application, right? And you see that, trajectory continue onwards. That's also some good data, for those patients who will be put on a topical as well, and that resonates just as well. And as another fact, I think is important that there is also evidence of head-to-head study of the topical JAK ruxolitinib with topical triamcinolone for 4 weeks before they were taken off of triamcinolone and switched over to ruxolitinib, and there was superiority on all the endpoints for the topical JAK. So you see that across the board orally, as we saw with UPA, as well as Abro, and as well as Ruxo for the topical. You see this consistent effect on itch, right, that also correlates with the quality of life. I think it's important to be holistic as we're thinking about this across the board.
Well, Naiem, let me follow up and ask you a question on that. How often are you prescribing topical ruxolitinib with an oral JAK inhibitor?
Oh, my friend. So this is kind of the bane of insurance-driven dermatology, right? So because there is that unfortunate boxed warning, in my opinion, right, on the topical, which I just can't, for the life of me, understand how that got it, but not the oral one. Doesn't make any sense to me, but nonetheless, coverage is one problem, but safety and efficacy in terms of my decision making is a different realm, not related to insurance. And I do give them both at the same time. There is no interaction. There should not be any interaction. The topical has very minimal systemic absorption, as seen, by the pharmacokinetic studies, has great efficacy. There's no medical reason from my medical judgment to not put the two together. Now, can my patients get the coverage? No, unfortunately. So what I end up doing is I focus on getting them the oral, and then I end up using the samples that are given to me for the topicals. So I'd rather get the coverage for the oral medication.
So Naiem, let's put all this together and help our listeners make the choice, JAK inhibitors or biologics. Choosing the right treatment is all about matching the therapy to the patient. In your experience, which patient populations benefit the most from JAK inhibitors? And are there any specific scenarios where you still opt for biologics?
So I think you have to go back to the science, right? You go back to the science and understand the pathophysiology that dictates what you're going to do for your patients, right? And knowing that the focal point of inflammation, and particularly atopic dermatitis, is through the JAKs. JAKs are critical, and they will, in my opinion, be beneficial for pretty much any patient. I ask you to find me a true non-responder, all right? Every single one of my JAK patients has had a response one way or another. Well, we can now pontificate whether or not, do you have a true response, just the magnitude of response, why could they be non-responding? We'll say that for another day for one of our scientific sessions, right? But nonetheless, given that understanding of the MOA, it should work. So safety is there, the MOA is there. It should work for pretty much anyone with good safety. Now, there you have your true contraindications written on the label, if their absolute neutrophil count's below a certain number, they have an active infection, pregnancy, you name it. Those patients certainly should not be on a JAK at that time. Neither for biologic, but there's some evidence for one of the biologics if you look at the case reports there. So in general, I see as everyone being a potential JAK patient. The beauty about having JAK inhibitors, especially being small molecules, quick on, quick off. You need to turn off the switch, for getting a vaccine. You got to travel, you got to do whatever. Turn the switch off. Great. Will you get recapture after you turn it back on? Yes. They've proven that, right? You have good recapture, barely loss of efficacy for recapturing. And then you have patients who, let's even say that patients want to be on it for 12 or 16 weeks and they're like, hey, doc, you know what? Still, I'm still not comfortable with that safety, whatever. Okay, fine. You give them their options, right? So these drugs is a platter, and you can come through and switch and mix and match as you want. This is a very innovative and golden era of dermatology where we have these medications at our disposal, and we can truly help our patients. Let's not, obviously, do not neglect your biologics. They're a crutch of what we've done and will continue to be. But JAK inhibitors have come and have been a monsoon, to the atopic dermatitis space, among as other spaces, as well as our understanding of the safety and the efficacy continues to get better. And we are seeing that these endpoints are getting more stringent and JAKs are hitting them more superiorly compared to the biologics. We should definitely think about them earlier on in our decision-making tree. Now, granted, I think it's important to say that on label and what the FDA is requiring in the prescription, in the PI, the prescriber information, is that JAKs are for those patients with moderate to severe atopic dermatitis with a certain age that are not candidates or have failed other systemic treatments. This includes phototherapy as well, like biologics, other systemics, et cetera. So by that very nature, it kind of puts it in the JAKs in a different category, but that's the semantics of what's written on the label. But in general, I challenge my colleagues who are listening here to really think about JAKs as something that they could run to in a safe manner and get really high-end efficacies.
Well said. I think to bring this back to some of the molecular discussion that we started with, I just wanted to point out that one of the reasons that the JAK inhibitors are well positioned to take care of patients that have failed a biologic therapy is because a lot of times these patients that are failing biologic therapy, they have molecular heterogeneity in the drivers of their disease. They have activation of other immune pathways, whether it's Th22, Th17. And we now know that in fact is occurring. A lot of these patients that don't respond to an IL-4 and or IL-13 inhibitor are in fact having other activated pathways that we traditionally had associated with psoriasis or other diseases. And in particular, one of the phenomenon that's been seen is dupilumab-induced facial erythema. And I think there was a recent paper attributing that to upregulation of interleukin-22, which can drive, it's kind of epidermal thickening, some of the lichenification type thickening of the skin. And being able to switch to a JAK inhibitor from a biologic like dupilumab that's leading to facial erythema is really important to have that option, because you're not going to hit IL-22 with dupilumab, but with a JAK inhibitor, you can. And that's just a real world example where I'm pretty sure every dermatologist that's written for dupilumab has experienced some of this kind of facial erythema or worsening of facial atopic dermatitis, which is now linked to interleukin-22. So with that said, Naiem, looking ahead, where do you see the role of JAK inhibitors evolving in dermatology? Are there new studies, new indications that you think are going to expand their use even further?
Right. So again, Chris, it goes back to MOA, right? MOA dictates everything. If you understand that, you understand how to treat, right? And so just briefly onto that head and neck dermatitis, right? That paper was in Nature Communications, and it was a nice transcriptomic study, which is RNA sequencing, and it really was illuminating for that pathway. And furthermore, one other major player that we don't really talk about is thymic stromal lymphopoietin, or TSLP. That's kind of gotten to the wayside a little bit with these exciting discussions, but don't forget that it's still there. And that also signals through the JAKs also. So this heterogeneity and all that stuff, they all signal through these focal points, right? So knowing that, and then the fact that there are 4 JAKs, that's it, right? JAK1, JAK2, JAK3, and our beloved TYK2 as well, right? And I'll tell you, so if you look at JAK1 inhibition in particular, JAK1 inhibition has been found in numerous disease states, right? Psoriatic arthritis, right? And we actually have a label for upadacitinib, right? You also have, I believe it's Crohn's disease. We have a label for that. Juvenile arthritis, there's, an indication, I think, somewhere in there, right? So there's a number of JAK-related inflammopathies, if you will, right? And then additionally, like from my own work, right? I'll just put a plug in for a paper that I had, and using deucravacitinib TYK2 inhibition for oral lichen planus in a patient that failed pretty much everything. And that's published in JAD clinical case reports. It's first in class, and so you see that these things have numerous potentials. TYK2 is also being studied for lupus erythematosus as well, and we forget also that JAKs are important for numerous cells for their signaling, right, including B cells, which can be important for a number of other, autoimmune conditions, and so on and so forth. I think we just are at the tip of the iceberg, my friend. I think there's more to come.
Yeah, and I'll just put in, we know that upadacitinib is in clinical trials for hidradenitis suppurativa, alopecia areata. So there are a number of other inflammatory and hair-related disorders already that are, we're talking phase three. We're going to be seeing data soon. And this is really exciting. It's transforming dermatology, to be honest. So to wrap up, what would you say are the key takeaways for clinicians when considering JAK inhibitors over biologics for their patients with atopic dermatitis?
Absolutely. So first is that there are head-to-head studies showing this superiority of JAK inhibitors for hitting certain endpoints, especially itch, within days, right? Within days. So you get early and effective outcomes. That's number one. Number two, safety is there. You have your 12 or 16-week data as well as your long-term safety data. It's all there. All right. And then access. Work with your teams to get access for these medications. You can get the help that you need to get those as well. Lastly, I want to bring up that we also have the data of those that had failed achieving the efficacy endpoints on biologics, and then you can capture those patients after switching them to a JAK inhibitor as well.
Naiem, it's been a real pleasure. Thank you so much for spending this time with me and talking about JAK inhibitors, science, atopic dermatitis. Your insights are very valuable. It's been a very deep and rich discussion, and I'm sure our listeners are very grateful for your time and your intelligence and your experience. And I want to encourage all our listeners here to stay updated on the latest advancements in atopic dermatitis treatments. You can do that at our Live Derm podcast website, where we have a series. This is the 5th episode in our atopic dermatitis program on JAK inhibitors. And we really thank you for tuning in and look forward to having you for our next episode. Thank you.
Thank you, everyone.
Stay tuned for our next episode in this series featuring Dr. Leon Kursick. Thank you.